As it stands,
as you're not agreeing with me, it is dangerous to stop warfarin without bridging. Well, okay, that's your opinion. Okay, what's your own point?
He was only to be bridged or dropped below 1.8. Now, I think part of the issue here with the bridging was that no one was checking his INR. Anyway, getting off topic. Checks his INR today, it's 1.2. So what I think we should do is when we discharge him, we'll send him with a prescription for both therapeutic Ahmed and warfarin. We'll get his GP to check his INR on Monday and take over from there.
Yeah.
He can stop his bridging once his INR is back in therapeutic range.
That's fine. Again, what's his INR for again?
His warfarin was for just AFib.
Okay.
Yeah. Okay. And the only reason he was for bridging was because, like, normally, of course, you wouldn't bridge AFib. The only reason
not necessarily until the patient is already AFib.
I'm hearing you, Professor Farag.
Well, I think Professor Peter didn't know that we are shifting to this new connection.
Okay. And you finish with the manuals, yeah?
I'm trying to send him a message.
إيهاب Professor إيهاب.
أيوة. Yes.
ممكن
Hello.
بس المايك عشان
Yes. I'm sorry. Just because I have to change from one link to the other, I did not. I'll meet it right.
Okay, no problem.
Sorry, I hope I didn't bother you with the discussion of my registrar. I'm sorry.
No, not at all. Okay. We are trying to contact Professor Peter because I think he didn't hear us when we told him that we are shifting to a new link. I'll send a message to him and another one on the WhatsApp. If not, we can start and he can continue his lecture after that.
Okay.
Just 1 minute if he is not joining, so I can start my lecture until he joins us.
Yeah, go ahead. Yes. Yeah, you can go ahead. We're listening.
Okay, can I start?
Yeah, you can start, Professor Farag.
Okay.
Yeah.
Okay. Can you see my screen now?
Yeah, we can see it.
Yes,
okay.
yes, we can.
Okay. Today is a real important event for me, and I think for our society, that it's our first meeting. I welcome everyone. Today I speak about this new approach in standardization of our colorectal lab. Actually, I started this approach in 1996 and published the first paper in European Surgical Research 1998. And then I had a book concerning this approach by Lambert. And I published some of the papers, including the pelviprenology. This is the problem we have now in the coloproctology. that the maintenance of continence appears to be a very complex phenomenon, anatomic, physiologic, and relative contribution of each being unclear. This is what is written in the literature when I was introduced into this field. Actually, I not speak in this lecture about obstructification alone, like my previous lecture, but the power of this approach is that it covers both the aspects of functional disorders. Actually, fecal incontinence is multifactorial. A lot of factors, we can't know the contribution of each. Actually, when you speak about what we drink, what we eat, the GI digestion, absorption, stool consistency, rate of rectal filling, rectal compliance, capacity, rectal sensation, reflexes, and all muscles, we can never, using our traditional methodology, know where we are and what is wrong in every particular patient. But why this? Actually, this was an editor comment at the disease of the colon rectum, speaking about the state of the art we have till now, is that it's a disseminated research methodology. It's a disseminated research data adding only to confusion. So the question was, do we have the right machines and we are doing the wrong measurement, or do we have the wrong machines and we have to have other machines to measure the anal function? Actually, I do believe that if you have a lot of factors that you can't explain, there should be a physical law which explains how all these factors work through a very small space like the anal canal and rectum in a fraction of a second to maintain continence, and in few seconds to achieve defecation. There should be a physical law. Does this law exist, or we have to find it out? Actually, this is the problem. The lack of answers to question how the anal sphincter works, mainly due to the fact that it's a highly integrated system. While we are doing the research in the traditional way, study one factor per time, per paper, this is not suitable for the anorectal system because one factor may be lacking and other factors are compensating. This can be explained better if we have another way to do it. So it came to my mind, why not the flow equation? I was a resident in neurology before I became a resident in surgery, and actually I was lucky to work with one of the early urodynamic machines. And this idea came to me, why not the flow equation? Because they use it successfully in neurodynamics and in hemodynamics. You know, all what they decide whether to stent or treat narrowing in a vessel is based on the flow equation. So it can fit blood, it can fit urine, but can it fit the stools or not? And gases, actually in the books of hydraulics, they deal with those things like gas supplying our homes and sewage drain from our houses as sewage sludge as very low viscosity and a high viscosity fluids. So there is a basis to use this in the coloproctology. Actually, how the anal sphincter works, using traditional methodology, I dare any word authority to say, tell me how the anal sphincter works. If we don't know how the anal sphincter works, how can we know what is the pathology and how to reverse the pathogenesis of the disease to be normal again? So we have to know first how the anal sphincter works, and this should be our information highway in managing our patients. If we look for the flow equation, can the flow equation solve our problems starting from definition of anal incontinence and constipation and going into steps further and higher? Actually, the definition of anal incontinence can be abnormal or involuntary flow of gas or stool during rest or during squeeze. I mean, if it's against the will of the candidate, it can be like this. You know, the classification types of anal incontinence, you always speak about passive urge, but there is a stress incontinence like the urinary, and it's mentioned by Swash. Actually, what the flow equation tell us, I mean, for those skeptical about the role of manometry, because they use the manometry to measure the anal canal pressure, and there is a major overlap between pressure in anal incontinence and normal, and in obstructive defecation and normal. So what is wrong with this? Let's see how the coloproctology looks like from the flow equation point of view. It's not my point of view. What we have in the functional coloproctology, like 100 pieces of puzzle scattered all over the place, we have to figure out how it will look like when it's fixed together. If we don't have this figure, it's Beauty and the Beast or Snow White or every nice picture we can have, we can't fix the puzzle. Let's see how, if we have a final imagination on how this will look like when we fix it, let's see how we can put the pieces of the puzzle. And if it works, we can trust. So the first thing which I met with the flow equation and was striking for me that flow, which may be abnormal flow like the inner incontinence during rest or squeeze, or low flow state during defecation per unit time, it depends on intrarectal pressure divided by anal canal resistance. So what we measure about the anal canal pressure by the manometry is not what we have to measure, because we have to measure the anal canal resistance. While in the rectum, which most of the centers don't do this, we don't measure the intrarectal pressure. So it can be useful if we use it in the proper way. This is how we measure the pressure in the rectum. And I'll show you what are the steps to do it in order to measure it in the physiological needed for the sake of application of the flow equation. And the anal canal resistance is very simple, can be measured from the lateral echographic views, rest, squeeze, and defecation. And we add also during coughing or Valsalva maneuver. This can be done also with the CT as done by Hilario in Brazil, or by MRI echography. But what governs the resistance of any tube, including the anal canal itself? Anal canal resistance equals the dynamic viscosity multiplied by anal canal length. I'm sorry, it's shifted the line, but it's directly related to the viscosity and length. We know that if the anal canal is long, there is a good resistance. We know if we have hard stools, it's difficult to empty because it's dynamic viscosity, the consistency, what we call the consistency. And if gases, it's easier, liquid stools, it's easier to leak or easier to defecate because the resistance, like any tube, like any glass tube, it depends on the length and diameter with the content, the consistency or dynamic viscosity. But we can see that the resistance is inversely related to the diameter. We know that if the anal canal is open, the resistance is low, the patient can have incontinence. And during defecation, it should be a wide diameter. So it's the first time to see this on paper. I mean, we know that the anal canal is good as long as it is long and narrow during rest and squeeze, and it has to open, decrease in length and diameter, irrespective to the mechanism of opening, which had been explained nicely by the integral theory or any other theory. But the final common pathway is to measure this. How to measure this? You can measure it simply like this. It's anal canal length, anal canal diameter. Now there is a very interesting program on the Google Play. I sent it to Hilario, and he started his first case of calculation yesterday and sent to me. It's very easy to apply to measure the length and diameter in a fraction of a millimeter. So we can have this, and simply we can have two of the factors measured by the lateral echographic view. The third is measured by the manometry, then we can have the results. Now we have this very interesting functional luminal imaging probe. It was used early in the esophagus and used vaguely in the anal canal, but we can see this wonderful picture where anal canal diameter can be measured in a fraction of a millimeter. And this, every ring like this is 5 millimeters, but if you want to measure it accurately, you can use also the image meter. You can measure it in a fraction of a millimeter. So you can have very accurate measurement of the length and diameter of the anal canal during rest and during squeeze, during defecation, but it's not still, we didn't standardize this in defecation, we still depend on the difficography, whether traditional CT or MRI. To understand why we have sphincters around the anal canal and why we have problems if we put synthetic material like cerclage, old cerclage, or the artificial anal sphincter, we can see this in this particular patient. He's not a very extreme example, but he's continent, defecate normally. During rest, we can measure the resistance, but during squeeze, this resistance increased 8 times. This can explain how we can withstand the increased interrectal pressure during cough or during Valsalva maneuver. While during straining, the resistance dropped 88 times. This means a shift from squeeze to strain by 720 times. No structure in the body or in the world can do this very nice job, except if we use the artificial sphincter, but this does under our volition, but it does this by the muscles, which can actively contract and actively relax during defecation. I will not go into the explanation how the muscle work from the point of view of the flow equation. It will be left to another time, but we can see this. So what are the mechanical factors maintaining continence? What we call the rate of rectal filling. You can notice this: rate of rectal filling, rectal capacity, rectal compliance. The final endpoint is the enterorectal pressure, and we know that incontinence is higher if we increase the enterorectal pressure more than it's needed. The incontinence increases by increasing the anal canal diameter raised to power 4. The most important from the flow equation point of view and mathematically is the diameter. We know this, and what we feel by putting a finger in the patient is to feel the length and diameter. Actually, you can measure this in a fraction of a millimeter. While the flow can improve if we give, for example, constipating agents to increase the dynamic viscosity. And of course, we know that the length is very important, and as the length decreases, the incontinence increases. This is the first time to see incontinence and constipation on paper. We can see this, we can calculate this, but in order to make it easier, the dynamic viscosity had been replaced by gas, replaced for air, the liquid stools with water, and the barium sulfate or soft stools with barium sulfate paste. And now we have only 3 factors to measure in every particular patient, and we can have very interesting findings. But how we define the incontinence? What are the classification which I put for the incontinence based on this lab? We can see the flow below 0.1 cc per second is normal. Even if there is a small gas less than 0.1 cc per second, is imperceptible, where the patient may look like a bubble at the anal canal. Sometimes they come with patients saying that we have a small bubble at the anal canal. There is no problem, it's almost normal. And if we have a low flow like 0.1 to 1 cc per second of gases, liquid, definitely of liquid stools, or for soft stools, it can be soiling. But if we have more than 1 cc per second, this is perceived by the patient as incontinence. We did a validation of the correlation of these findings with the patients and found very good correlation ranging from 75 to 92% in the patients. So we can have now 6 levels of continence, either normal, fluid stool soiling, soft stool soiling, incontinence to gas, fluid stool, or soft stools. This, what I love in the flow equation, it's not, I have a calculator, we can send it to you by WhatsApp, and you can put the data and it will give you the diagnosis. But you can see this very interesting finding that usually there is a confusion between the anal staining while there is a normal sphincter and the soiling, the true soiling, which is stage 3 or 4, whether liquid stools during diarrhea or for soft stools. The only difference which you can ask the patient for, and this is very important, you have incontinence to gases, which is 2, because they can never jump from 1 to 3 or 4 without going into 2. So the simple question, when the patient say, I found some stools or pieces of, or some liquid which look like stool during diarrhea, I ask him, do you have a gas incontinence? If he say no, I look for simple anorectal problems or other reasons. This is a magnification of the zones which we spoke about, and we can have very interesting imagination on the degrees of incontinence and grades of incontinence, and the flow equation and the normogram is also available on our website. You can use it, can be compared to the patient symptoms. It's very challenging to see the patient symptom in our lab because this was not achieved before. We can make the measurement easy by connecting the anal canal length and diameter on this normogram, intrarectal pressure, and we can see where the patient lies. In this particular case, the red lines of this particular patient, they have fluid stool, frank fluid stool incontinence, while in the green patient, they have minimal soft stool soiling, water stool soiling with gas incontinence. So can the equation solve our controversies in anal incontinence? We can see this, that we have 4 mechanical factors, only 4 mechanical factors. The intrarectal pressure is the one which should be measured. The anal canal pressure doesn't show itself, and that's why the manometry had a bad reputation. It's not bad, but we are doing the wrong measurement. And the interrectal pressure is the final common pathway of rate of rectal filling, rectal capacity, rectal compliance. Anal canal length and diameter are final common pathway of the pelvic floor muscles, ligaments, and anal sphincters, including the 4 sphincters: the circular, the longitudinal, the internal, and the puborectalis. While dynamic viscosity is the summation of what we eat, what we drink, the GI, motility, absorption. So all the factors which mentioned in the first slide, which look like a chaos, now can be structurally found in this. The anal canal pressure doesn't show itself, so we can't rely on the anal canal pressure in measurement of the continence or defecation. The anorectal angle doesn't show itself directly in this equation. So the importance is that it's just an indication of the action of the puborectalis, whether it's good or bad, and we can measure the anorectal angle shift during squeeze and during defecation as a measure of contraction and relaxation of this sphincter. But sometimes the puborectalis is ill while the external sphincter and internal sphincter are okay and the patient is okay. This led to the confusion about the anorectal angle. The perineal descent. Perineal descent shows itself in this with the intrarectal pressure. And I think Professor Gottsman will speak next week about the dissipation of power of straining if we have perineal descent. And there is a study from Italy. They have a perineal support at the level of the transversus perineae, and they found that there is increase in the intrarectal pressure from 40 to 60 during defecation. So this can have an effect, but indirect effect, but through the interrectal pressure. We are trying to find what's right and what's wrong from the flow equation point of view, not from my own point of view. This is a model, so we have to look at it as a mathematical model. The frequency of anal incontinence, I agree it's very important for the patient, but it doesn't show itself here. And I remember a talk between me and Professor Wexler when I visited him at the Cleveland Clinic, Fort Lauderdale. I told him if we include the frequency of anal incontinence, even using the traditional scores, including the Cleveland score, the patient, if he has a stress incontinence, if he has cough, for example, in winter due to bronchitis, he will have a worse score. And if we give him cough mixtures and some antibiotics, this score can improve. We can conclude that cough mixtures and antibiotics improve continence. Frequency should be included, but I'll speak about this, that it should be another category beside this clinical evaluation or lab evaluation. This was the first step, but how? The sensory and reflex factor, this second level of integration. If this equation can solve the problem, how to integrate and numerically calculate the sensory and reflex factors, this equation wouldn't be good for us. If we have a delayed rectal sensation and the patient become incontinent. Why they become incontinent? Because there is increase of intrarectal pressure. I'm sorry. Two sensory factors can affect intrarectal pressure. If the patient has very early sensation and very poor compliance, the compliance means change of pressure per change of volume. This will affect the pressure, like the case of proctitis, for example. They cause urge. While the reflexes affect the resistance. If we cough, for example, the anal canal lengthens and narrows. If there is a reflex inhibition of the sphincter, there is shortening and widening. So for every particular patient, as we can see later on from the examples, we can calculate mechanical, sensory, and reflex factor. This is very, very important. The first time in the lab to be done. This is the only way to do it. Of course, I can welcome any new integration, but this is the only factor which can solve this question. How the anal sphincter works, what are the mechanical factors, how we quantitate each mechanical factor. So if we do more than one treatment, we can know the effect of each treatment. For example, if we treat the proctitis, if we give something which relieves the rectal contraction, we can know this through the rectal pressure, and the reverse for the anal sphincter. If we give biofeedback, for example, it should work through the anal sphincter. But if we want to give a sensory biofeedback, we can see this in the interrectal pressure. For example, in the case of passive anal encounters, what we measure in our manometry, again, manometry is back into function through this equation, through measurement of the intrarectal pressure. So we measure the intrarectal pressure during rest, while we can measure the anal canal resistance from the echography during rest. But if we have a sensory deficit, how we can quantitate the sensory deficit? In this particular patient, with delayed sensation, instead of 30 or 40 with the first blue quadrangle, we can see its delay, and this led to increase in the pressure by 19. But in this particular patient, there is something which happened, that the anal canal had severe rectoanal inhibitor reflex, profound rectoanal inhibitor reflex at this pressure 19, and this can explain and quantitate the degree of this incontinence and the reason of this incontinence. There is a combined delayed sensation and a reflex problem which is initiated earlier in this particular patient, so we can work on this. For stress anal incontinence, for example, during cough, we can measure what happens during cough. We can see the curve with the above. This is the interrectal pressure, this is the interanal pressure. It goes perfectly well with the cough. So the anal canal depends itself properly, and we can measure the anal canal resistance during cough, and then we can have, we can be sure this patient is normal or not. But look at this curve. The patient coughs, but what happens? The anal canal doesn't contract properly. So what is wrong in this particular patient? That this increased pressure, which may reach up to 70, 80 millimeter mercury, challenges the anal canal resistance at its rest. We can measure that this is a problem in the reflex contraction of the anal sphincter. We can understand that. We can never understand except with the flow equation. But during urge, for example, in this particular patient, during urge, the pressure rose in the rectum to be 59, and the anal canal resistance during squeeze, we can calculate it and see the effect on this. But in this particular patient at urge, before he reached the toilet, this happened. The anal canal resistance dropped. Now we have a very interesting, but we didn't publish yet, what we call manoflip. We can put the flip in the anal canal to measure, while simultaneously putting the balloon of the manometry in the rectum to measure the pressure and see what is happening in the anal sphincter. So we have to standardize our colorectal lab based on the flow equation. How to standardize this? It's very easy to do traditional difficography, MRI difficography, or CD difficography, but we have to standardize the manometry. This is the standardized manometry. You can see the upper curve is in the rectum, and the rest are, this is at the junction area, and this is in the anal canal. We measure the following to be able to study the anal sphincter properly. During rest, this is the anal canal during rest. During squeeze, what happens in the anal canal during squeeze, the pressure. During cough, during attempted defecation, push on the empty rectum. And this is the rectoanal inhibitor reflex. We can see the reflex inhibition, which happens here, but it recovers. This is a normal reflex. During the first urge, what is the pressure and what happened in the inner sphincter? We can see this drop, which is extensive a little bit. In the first urge, also we can see this. This happened, and the inner canal resistance dropped for a long time before recovering. This is the intense urge. It didn't recover up to the intense urge, but this means that the inner canal relaxes abnormally. This abnormal rectal inhibitor reflex. This is a new type of incontinence, which I mentioned in my book. This is the reflex anal incontinence, which can exist without sensory or mechanical defects. And this usually the cause of the incontinence after hemorrhoidectomy. This is strange, but this had been reported by other authors, but they didn't, characterize the reflex anal incontinence. They said in patients with the after hemorrhoidectomy, when they have incontinence, they have this profound early rectal inhibitor reflex. We mean by profound relaxation of both the internal and external inner sphincter. This includes the work of Professor Andre Zubar from Israel. And actually, this is the endurance squeeze to see if the anal sphincter can contract for a long time. And this is very important, which we rely on during defecation when we try the balloon expulsion test, and we can calculate the mean intrarectal pressure. I say during defecation, we have to measure the mean, while in the incontinence, we have to measure the maximum, because incontinence is an accident, should happen instantaneously, while defecation is over a period of time. But you can see in this particular patient, you can see the curve is very hectic because the patient is contracting from his abdomen. If we see a patient doing this, we can put our hand on his abdomen and ask him, don't strain from your abdomen, and we can uncover what we call a rectal inertia, which I characterized again in my book and mentioned in my previous lecture. Now, we can reach to the fact that knowing how the anal sphincter works will help us in the relative contribution factors responsible for the anal incontinence. If they coexist, the relative contribution of sensory and reflex factors equals the flow after correction minus the flow before correction, like this particular patient, and even can determine the patient selection for treatment. For example, in this particular patient, we can start a sensory biofeedback, just having a sensory biofeedback to make him feel at a lower pressure where the inner canal can withstand this. This can warn him to go to the toilet area. And actually, it helps to select patients for direct sphincter repair, because sometimes patients with incontinence, they have other problems like sensory and reflex, and we go repair their defects, but their resistance is normal. If we find an inner canal resistance during rest more than 4,000 using my calculator, or on the normogram, or squeeze more than 7,000 to 8,000, it can withstand very good intrarectal pressure. So we shouldn't go to repair this, because most probably the patient will still complain because he is another cause like sensory and reflex, which can be detected in our lab if we standardize our lab. How the anal sphincter works help us also in predicting outcome, operator independent assessment of treatment, assessment of different treatment modalities if used simultaneously, and planning for new treatment modalities. If you want to test it, like Ilario started his first case yesterday, and he told me that it was very easy. You can send it to my private WhatsApp, or to Dr. Mahmoud WhatsApp. I'll do the calculation from the defecography, and you can send the mean intrarectal pressure during defecation, and I'll give you the results, and I'll send to you the calculator with the program image meter, which I use for the calculation. As Einstein said, knowledge is power. If we have knowledge about the anal sphincter works, we can be powerful, we can be strong, we can help our patients better. So thank you, and this is my website. Thank you.
Thank you, Professor Farag. And now we can shift to discussion. If there is anyone want to ask Professor Farag about the lecture.
Thank you so much, Prof. It is really interesting as usual, you know. I enjoyed it. So if you can send us, all of us, the calculator as well, would be great on our WhatsApp group, would be great.
Yeah, sure, we'll send it with the image meter. You can send the first case just to me, just to check with each other if we are okay. Ilario started his first case yesterday, so he can help us to mention his own personal experience with this. It's very easy. It's 5 minutes job to do the calculation, and you can have a lot of information which can help you.
Sure. Thank you so much. Thank you. Great job. Thank you.
Professor. Hello, everybody. Congratulations on this beautiful master class. It is very interesting. It is how to simplify a very complex condition, a very complex situation. It's a very complex concept, and by this idea of the flow and the formula, and it all becomes very easy for us to calculate, for us to understand. And now with the way to perform it, it is very easy. It is a powerful way to understand our patient. So I encourage all of us to start doing this as soon as possible. So congratulations, Professor. Very good indeed.
Thank you, Ilario. This is I'm very happy because just we have one case before and we shared it with each other. Now you started your own. I think it's also good to calculate and assess this symptoms with the patient symptoms, and we can, by the end of the year, have hundreds of cases which we can report in a very interesting paper on the correlation of the colorectal lab using the flow equation. And now we have very eminent professor that's in the society, as Asif was mentioning, that we want to publish in high impact journals. And I'm asking Professor Gottsman if he wants to share with us. I mean, it's of course an honor for us to be a member in this society, but just cooperating with us is more than we need. Your opinion, your experience with the technique, and if you are convinced you can help us to spread the word. I think we are planning to have something different, because we are all in this society are unhappy with the old functional coloproctology.
Yes, really amazing.
Yeah, thank you. I have to remind you that next Friday, the same time, we'll have this very, very interesting lecture from Professor Lester Gottsman. Is very brainstorming, and they will discuss this his findings from the flow equation point of view, because this is a very good test to see the flow equation, how it can explain the literature. And actually, I have on my website what I call the crystal ball. You can look at any literature through the flow equation. I mentioned two of them, including the artificial anal sphincter and the other, how we can explain the results mentioned by the investigators.
Yeah, that would be great. I'm really excited to hear that, you know. Yeah. So I'll wait for next Friday, yeah? Okay.
Yeah, sure.
Okay.
Do you have any questions?
I have to go back to work.
Okay, I imagine. I'm sorry for keeping you for a long time, but your existence was very important. Okay. Thank you, everybody, and see you next week, inshallah.
Thank you. Thank you. Thanks, bro. Thank you. Bye-bye.
Bye-bye, everyone.
Thank you for all of you. Thank you, and see you at next Friday.
Thank you. And it's already scheduled next Friday.
Okay. Bye-bye, everyone. Have a good day.
Bye-bye.
Bye.